I'm Matthew Bolson. I'm the Senior Associate Dean for Global Health here at School of Public Health and a Professor of Epidemiology. And I have the honor of serving as the Associate Director for the Center of Global Health Equity, where I work with Dr. Joe Kolars, the Director, and the wonderful Center staff who made this event possible today. I do want to mention that today's event is co-sponsored by the Center for Global Health Equity, Global Public Health here at the School of Public Health and the Department of Anthropology. The Center's seminars an opportunity for our UOM scholars and their global partners to engage in an interdisciplinary dialogue around some of the most critical issues in global health today. And we try to do this in a solutions-focused way. We're grateful to have so many of you in the audience today from diverse academic units. I understand from the Center stand that we have attendees from social work, anthropology, public health, nursing, medicine, the International Institutes, the Board Policy School, Environment and Sustainability. It's activists, like our university. We hope you enjoyed this session today on migration, global health, justice, facilitated by our colleague Scott Stonington. Dr. Stonington is a physician practicing primary care as Ypsilanti and hospital medicine at the VA Ann Arbor Medical Center. And he is an associate professor of anthropology and internal medicine, wonderful combination, at the University of Michigan. His research broadly addresses globalization of biomedical ethics and expertise, and he is currently working on books on pain management in Thailand and motion and improvisation in U.S. clinical medicine. We're very grateful to Scott for sharing this expertise with us today and for facilitating an important conversation with Dr. Mayssa Rekhis.
Hi, everybody. So today we have the great privilege of having Mayssa Rekhis. I'm getting closer to being able to pronounce the name with us. And part of why we're so privileged is because her background, I think, is going to leverage for us a way to think about lots of tensions and both productive and awkward in global health. So that background is, Mayssa is a physician and an anthropologist. She trained as a medical doctor at the University of Tunis in Tunisia. And then in medicine, felt like medicine didn't give her the access to the forces that she was most seeing that were affecting health, that were coming from the social world. So she had a stint in the nonprofit sector in North Africa, Middle East, and the Mediterranean region of Europe, which I think will also be very helpful for us. And then, wanting more of the social world, she got a PhD in anthropology at the École des Hautes Études in Paris. And during that time, she did her PhD fieldwork in a clinic in Sweden that was a clinic for trauma therapy for refugees and immigrants in Sweden, which then led into a job that she's had since 2022 at the School of Public Health at the University of Gothenburg in Sweden, where she is a lecturer and runs the Masters in Global Public Health, Masters in Global Health, right? So, welcome. Thank you.
Thank you so much. And hi, everyone. I'm very happy to be here and looking forward to discussing different issues with you today. So thank you for the invitation.
So I've prepared some questions. I'm going to lob them to Dr. Rekhis, and then we're going to have a Q&A at the end. So the theme of today's talk is going to be about the relationship, both conceptually and logistically, between how we imagine the center and the periphery of where health knowledge is made and where health decisions are applied in the world. This is something very central to global health at the moment. And I thought we could leverage, Mayssa, your biography to think through this a little bit. So my first question is, could you walk us through a little bit of the experience of medical school in Tunisia as you were training? And in particular, how did this figure of the global and global health and where medicine came from and where it was applied, how did that show up for you in your medical training? And just as a little bit of a preview, I imagine Tunisia to be a complex peri- and post-colonial place with language complexities and et cetera. So we'd love if you could walk us through some of that.
Yeah, I will maybe start with exactly that, the post-colonial part, saying that medicine is taught in French. And so all the medical training is in French, and not only. That's also, so the country is officially an Arabic-speaking country, but French, as it has been colonized by France until 1956, has still kept being a very central language and has been the language of science. So even in high school, for those of us who go into a science path, everything is in French apart from philosophy, Arabic literature, history. So the humanities would still be in Arabic and everything else in French. But this, in medicine, was sort of always in contradiction about what the language was in the clinic. So we were learning medicine not only through etymological framework that may have come from other parts, but also in a different language than the one we practice it. And that was, I think, a very interesting clash. But of course, as a very young medical student, you don't necessarily see in all its complexity, but it was a challenge. It was just a challenge about how to talk to patients and explain what you won't be able to explain in the language you're speaking with them. Everyone speaks Arabic, and dialectical Tunisian Arabic has some French in it, but it's still very different from the French. And I think even if there's already, for people who are in the same language, learning medicine and or any other health professional work and practicing in the same country, there is already a difference in like what kind of jargon, right? The word you won't be able to use necessarily to explain. But that was coming with a different layer, the fact that it was a completely different language. But that created all that part where it was also possible to talk about patients around them in staff visits in a language they won't understand. Not all of them don't. So it's like, maybe I need to give more context here. So many people are bilingual, but not everyone. So it's more, like highly educated people will be more bilingual. Others are not. And in the hospital, in public hospitals where you meet everyone, and actually mainly people from lower socioeconomic classes, there is also a parallel private system where higher social classes will go. So that clash was there. I remember, like as a student organization, at some point they made this little guide, which was some sort of a dictionary about the different names of just the symptoms in Tunisian. So they did a little dictionary that was given to students. That was student who did it. It was never part of the plan. So I think language in itself is already some sort of very complex issue in relation to coloniality and so on, but not only. It's also what you are learning in terms of many times learning about diseases that do not exist, and not necessarily learning about ones that exist in your contextual place, because most of the books and textbooks do not come from the place you are in. So I think that's already some sort of my first lived experience of the clash between how what you are learning may be completely clashing with what you are needing to practice.
Follow-up question to that. I have a feeling we're already going to get some questions in the Q&A about this, as many of us in this room end up traveling a lot as we think about our populations that we're working with, et cetera. As you talk about that, it sounds very structural, meaning there's language, the textbooks come in French, the medical education is coming in French, and then was the atmosphere, did the atmosphere track with those structural things? Like, was there this sense that, I'm thinking about in lots of people who do ethnography of global health, there's this phrase that people use, which is that real medicine always seems to happen somewhere else, so that when you're training in a place, it's sort of like, oh, well, I got to get to France where like real medicine happens because that's where my textbooks are from. But then there are students in France who are like, oh, I got to get to Tunisia to practice real medicine where I don't send everybody for a CAT scan and I actually have to listen to their heart and I have to So I'm wondering a little bit about like what came with that atmospherically in your training.
Oh, people were talking about real medicine in both ways. So I think sometimes we are welcomed in clinical rotation saying, now, welcome to real medicine. You'll need to not forget about your books, but like you will need to expand everything you learn because there will be different things to navigate. But there was a lot, though, in internships, people want to go indeed a lot to France, and there are all these. And that's another thing about the post-colonial part, I think, that you see less critically when you're in there and just want to go to France for an internship because you will learn more and get a bit more prestige coming back and more opportunities, but also that actually big numbers will stay. Public education in Tunisia is for free. Medical school is for free. And it's a big investment. It's one of the most expensive educations for the state to invest in. And it's a country that lacks doctors. But these doctors who are taught in French go to France for an internship, and usually they will be offered positions because France needs doctors, and it's less expensive to get doctors who are already trained. So that was also another thing, but it was not seen critically as much in the way that at some point there was, and that was during my education, that there was this Minister of Health who felt like, oh, we're having a big brain drain and that's a big problem and we want to just limit. So there will be no more internship that could be allowed in the training in France. There have been strikes for months and big demonstrations because people considered that was taking out their possibility of choice and that was limiting their possibilities of training. Funny enough, this person later on is now a practicing doctor in France, the Minister of Health.
So I'd love to zoom forward because I think we're going to start talking more and more about the content of your work, which is ultimately about migration and borders. You yourself migrated to France in at least for a while for some of the same reasons you just mentioned. And then you ended up with this project at maybe you can tell us a little bit about your clinic to start us off, but at this clinic that was for people arriving whose claims on being in Sweden were partly made by having had some form of trauma where they came from. And so there's something there about how Europe, at least at the time, might have been imagining why people are coming. Like you're coming from something really bad, which is why you've come to the country. And I'm wondering if that is, part of the vision of what it meant to be a refugee or an immigrant showing up in the places that you were in Europe. And I'm wondering also a little bit about, I know more about your work, so I'm asking sort of leading questions, but, we imagine that when refugees arrive, they have all of this trauma from where they've come, and then now they get to relax and everything's going to be easy and okay, sort of forgetting all of the parts of the rest of their life and what that experience is like. So I'd love for you to bring us a little bit into your own view and your own fieldwork also of the journey from a post-colonial place to a colonial center.
So one, I would say that one of the interesting parts is that it never saw itself as a colonial center. And that's because Sweden was not involved in colonialism according to its official history, or at least the one that everyone talks about, because they had a little island that they colonized, and they were involved in colonialism through other collaborations with colonial places. And I think for me, arriving to one particular clinic, and I will talk about it, was also getting out from in a different role and with different tools. So what I am speaking about, like I was speaking about, was really what was allowed with like just having this frustration and these clashes and not being able to understand everything. And then going to social sciences that are very much focused on everything. So I was a little bit more equipped, I think, in that sense, going to that clinic. So to talk about, all these borders in that sense, that clinic is a trauma therapy clinic for traumatized refugees. And it's a clinic in Sweden that is specialized on trauma therapy that only serves adults who got their residency. So not working with asylum seekers or undocumented, so only refugees in the legal term of it that they got. The trauma was, there were criteria in the referral form: due to torture, to war, or to migratory journey. So these are the experiences that the person was allowed to go into that clinic. And that's how it was mainly presented. That the idea is that, yeah, people were traumatized because of somewhere else where there have been persecution, war, or the migratory journey, because it is a difficult journey, mainly due because borders are closed and they are hyper-violent. So people die in the Mediterranean Sea, in the Baltic route, walking to different places. And these were perceived as traumatized. But exactly as you said, people usually were like, yeah, but now that's over. You arrived here, there are no bombing, you're safe. Forget about it. Even arriving to that place was sort of almost denied that you were able to be there. And then I remember sitting once with one of the therapists in the clinic. And I heard some people are from anthropology and some are not. So I would say something that I didn't know when I was a medical doctor or studying medicine about anthropology, that your main methodology is ethnography, which means mainly hanging out with people in these spaces you want to explore, doing participant observation, which means you're there, you observe, but also not like just as a fly in the wall. You're also in the interaction. So this is what I did for my work. So I was doing an ethnography of that clinic, which meant also hanging out with the staff and talking about them. And this therapist said, the whole framework we're working on is a framework that is racist by definition, because we are only seeing that their home country are traumatized, and we're not seeing the trauma we are inflicting to people here. And that comes from restrictive policies. People were getting very short residency permits with all the uncertainty that they can be sent back to wherever they are if that's deemed safe, that they were denied family reunification so that they can get their children still in refugee camps in some other places in the world and not be able to get them. And all the different, I won't give all the forms of violence that is happening every day. And that, I think, is also a bit what is sometimes embedded in some of the global health work. And that maybe I can come back to something that is like now I'm thinking about, is that the worst of what is happening elsewhere. And this is where we need to act. And that was transposed in the clinic also. That the worst that happened to this person is what happened to them in Afghanistan or in Syria or in Eritrea. And the focus was there. And the other things that were happening in the place of, it's called host society, right? In migration, we speak about host society. I always cannot write it and add this ILE, it's also hostile society. This is how it is described. And this is not seen. And this is sort of mirrored also. What I wanted actually to say is that as a medical student, I was part of the International Federation of Medical Students Association. My understanding is that it's not very big in the US, but it is in many parts of the world, and medical students go and so on. And there was an initiative that started, now I'm not sure, 2010 maybe, that was called Global Health Task Force. And I think it's like global health starting to be big, and students were super interested with the big slogan, think global, act local. And I joined that as a representative of the Eastern Mediterranean region, left very quickly after because of this exact thing, that it felt that everything is good somewhere and everything is bad in the other, and nothing was linked into the interrelations of what is it making it bad somewhere else. So if we go back to Tunisia, one of the things about the healthcare system is that it was, when colonialism ended, there were no universities of medicine or nursing or anything. Healthcare was very impoverished, and all the system was very weak. And then you have all these powers that actually make it keep weak. And I think many times there is this imagination that, yeah, it's like all the problems happen there because of these people who are there. They have violent culture. And then this is the problem.
Thank you. Building off of that, I'd love to hear your thoughts a little bit about what's happening right now in Europe and European public health and global health thinking, but also just broadly and politically in Europe. My sense, I'm pretty ignorant about European current events, but my sense is that there's a little bit of a reckoning happening about suddenly feeling like the borders of the EU are porous in a way that they weren't, and there's been a big pendulum swing in relationship to refugees and migration. And I'd love to hear about whether, what's happening now in thinking about the relationship of academic life. Many of us here are in public health. We're designing projects, we're applying for money, we're going places, we have to pick a population and a problem and define it. And I'll just come out and say that if your problem you're talking about is really complicated and with the place is fraught in some way, like if you're saying, I want to focus on people who have traveled through 12 Latin American countries and then illegally crossed the border in the United States and then are in this place, it's like, where's it's harder to get money for that kind of thing, et cetera. So I'd love to, in your work, thinking about borders and migration and all of that, like what's going on right now in current thinking about how to help people like us who are trying to place ourselves and find problems in public health.
Yeah, I think there is definitely a movement happening right now in global health that in my university, the history of the global health program is different from its current state. It started that it's different from the public health master program because the public health was more focused on high income countries and the global health was focused more on low and middle income countries. So there was this idea. And it's not anymore. And we are now having all these discussions whether does it make sense to have a public health and a global health master programs going in parallel? Shouldn't we have a global public health master and merge them? So it's an ongoing discussion. And partly because the definition of global health being public health that we do in low and middle income countries is not standing anymore. And there is this big movement, I believe also in the US, of decolonizing global health and that we cannot keep on doing the same things. And they haven't been bringing changes. Like we still have the same inequities, the same disparities, which means that there is something that needs to be changed. So this is happening. There is also the part that is happening saying, yeah, there has been, and I think, of course, migration seems to be more central. And in surveys about the main things that people are interested in the European Union countries, migration is now part of the top 10. It is very mobilized in elections. I believe here too, and in other parts of the world. But it has always happened. So what is happening more is sometimes that it's just hyper visible, partly related to the fact that borders are becoming more violent and closed. There is this whole idea of building a fortress Europe, because the borders are open within the European Union, and that's part of the project, but then it needs to close down more. So migration is very present, and then people are saying, oh, we need to have global health tools also used in our local community to work with people coming from other places. But the problem stands here. It's we are still thinking of the other people needing global health and not ourselves, and not thinking about actually the bigger structures and powers that make the interaction problematic. What is the reason that we are the deep root cause of these inequities? It's multinationals that many times are actually a big space that global health could act on, like food industry, for example, if we are speaking about all the non-communicable diseases and diabetes and the issues of processed food and so on. This is an action that is there. So that now is also coming in. So I think there is a part in relation to migration, but there is a part that people are no, we cannot continue saying it's the other that we need to act on as a global health action. We need to act on the root causes of inequity, on the policies, on, wars, right? Like, that's the thing. Like, how can we have less trauma? We can have trauma curriculum, and we need to have them, and there will always be. But one of the reasons also is like, maybe to think about stopping arm trade, not sending arms to these places would be a better action. So people are bringing these discussions now in global health in a way that is provoking, difficult sometimes, because it brings also these questions like, is it now my responsibility that I need to look at? But it's exactly that. It's about looking at a deeper way of doing change. So I think, and it's of course not happening like in a smooth way, not saying like but there are a lot of discussions that are happening that are, I think, interesting, and that are a very important opportunity for us to make global health what it is about, is that it is equity in health for all, everywhere. The issue is that there are disparities even within very high income countries between the poor and the rich. And that's also a global health issue in a way, because you can learn a lot from it. So I don't know, now I feel I talked a lot, but I hope I still answered your question.
You totally did. So you mentioned the word decolonial or anti-colonial a couple times in there. And I would just love if you could give us some examples or any inspiring things, especially about the way you were talking about, there's a here and a there and a resources here and an object or a problem that is them or other. So I'm wondering about research projects or interventions that somehow don't operate that way, that are about, I don't know what, collaboration or...
Yeah, so lately I have been, as coordinator, director of the Master of Global Health, part of this discussion in the Nordic Global Health Network, where we're thinking a lot about decolonizing global health. And there were always even this question, would global health survive its decolonization? Can we still do it? Is it the whole premise? And I remember we were sitting with brilliant people coming from all different disciplines, working on global health, working on programs, thinking about how can we do that? How can we do that practically? And sometimes it felt hard and there was no clear action plan. In parallel to that, I was lucky to be part of the art project that I can say a little bit about. So it was an archive of midwife, who is the mother of the project lead, this project, who passed away a few years back. And then opening boxes and cleaning the house, she found out that she had one box about all the work she did as a midwife in Tunisia in the 70s. So she was a midwife, practicing mainly in Sweden. She went to Cambodia at some point, but there was this whole box about working in Tunisia from 1970 to 1975, part of the National Family Planning Program. And that's a project about I can bring some photos while I talk about it, just to give you a sense. I'm still sad that I didn't bring the book. I was I forgot about that. But I can get you some photo here. So that's, she kept everything so that's the SIDA, so the Swedish International Development Aid, the sort of publication on their work for development in Tunisia. So it's work for development in Tunisia. And these were given to the workers who will go in this development work. And that's, somewhere in 1970 or 69 probably. To all the brochures she was using in the clinics on family planning. So the condom, that's a word that is the same in English, but it's a condom is one of the best methods that you have, explaining everything. Then, the contraceptive creams, that is not that popular now, but was at some point where the main objective was not to make sure that you don't get pregnant, but to get pregnant less often. That was also the logic. So as it is not super effective, but still, to having all these programs about the family planning and how they are implementing it, to photos, educational material that was used to educate assistant nurses and so on. Okay, and that's some text. And that's Elsie Salomonsson, that's her archive. And that's the cover of the book, which is, a lot of people don't know what this is, but it's, a baby being born. And that's one of her doodles, actually, that she was using to teach birth, doing her work. And then there is some text that was part of a little bit my work coming into that project. And maybe it's got something else here, which was reading a little bit about the context. Of course, going through all of the material, and here there are a few examples that they were like newspaper cuts. They were diary notes. And reading a bit about, what happened in that era, what was in the 1970s. So in a way, it was not called global health then. It was more this international development framework that was there. The Swedish Institute, International Development Aid, working in Tunisia. But it was some sort of premise of what it is, having health professionals go to settings to support them. And then what was super interesting is that I was doing this contextual research and looking at how that was done and how it was mobilized. One of the main things that I found super interesting was one of the visions of one of the funding sources saying that we only intervene when the country asks us for, and we only do what they ask us to do. And that was very important, which is oh my gosh, that felt like we can learn some of the things there that seems to have been forgotten in the way, where there were interventions that were not necessarily part of the planning of the country. And then there was all this part on how the government at the time, in a very, it was just after colonialization, it's that 1970 is 14 years after independence. And it was the government needed to build the whole healthcare system that was completely down. And it started with medical school. The first one was started in 1964, so less than 10 years after independence. And at that time, there were the first midwifery school opening. And they were we need to get the funding to help. Family planning at that time, for several reasons, was very popular. And one of the why the Tunisian government at the time found it important to follow was that it was a way out of poverty. If we reduce the number of people, we will be able to better distribute the resources. And that was a big part also of all the newspaper cuts. That's our way to development. We need to have less people, we will have less poverty. So that was very much about it. Also that we need women also to rebuild the country after independence. And if they are having a lot of children, they won't be able to work. And we are losing half of our society not working. So that was all that. But that was family planning has a lot of funding available. And they use that funding not only to work on family planning, but to strengthen the local healthcare system. That is part of what global health ideally wanted to do, but hadn't done with all the short-term interventions many times that they end, and there is no sustainable strengthening of the healthcare system. So in a way, I sort of, going through all this archive and context, I sort of said oh my gosh, we may learn some of what it means to decolonize global health of what it was in the 70s. And even in the diary of Elsie, there were all this questioning is sometimes and she says it in a more poetic way, and she's a very poetic person writing her diary, what it means to be a foreign person in that country. Do they really need us? Are we really helpful? How can we make sure that we are not making more harm? These were in the discussion. And I believe that's very much because it was very close to the decolonial movement. So it was all the independence movements and people were very careful about it. But what happened is it seems that a few years later, this was sort of forgotten by global health funders and institutions and so on. But through this project, I also felt it is less of a utopia. It's it's probably to do things differently, even if not exactly like the 70s. It has also its limitations, but some of it happened.
So I apologize if I get too enthusiastic about this point, but we tell the history of global health usually as, I won't go all the way back, but as having this wave in the 70s and the 80s around leading up to and after the Alma Ata conference, which was this coming together of the United States, China, and the Soviet Union as this kind of triad block of power, where they were working out the tensions between the very, very different styles about how to do governance of each of those. And one of the ways they did that was with this idea of like really locally driven, appreciative learning, horizontal healthcare, which was about, China was contributing a history of the barefoot doctors who traveled from village to village, and Soviets were talking about really distributed resources, et cetera. So there was this wave, and we usually tell the history of global health as that having been this kind of like fantasy for a little while, that then like the reality of economic life and neoliberalism that came after the OPEC crisis and stuff came along. And it was just like we were deluded for a little while, thinking we could all cooperate and use local expertise and local priorities. And then the like realities of the 90s and 2000s came along. But what I'm hearing from you is that there was like like a convergence of something of post-revolution and that hopefulness that not just made enthusiasm, but made a whole bunch of real, like the actual health system of Tunisia. First of all, am I hearing that right? If so, that's very interesting and cool. And then the second question is, so do you feel like by the time you were in med school in the 2010s, like medicine was more colonial than it was in the 1970s in Tunisia?
I will be extrapolating a bit, as I wasn't in med school in the 1970s, but I would say so in the sense of how it was. I think what's happening is that how you can interiorize and naturalize the power structure. And in the 2010s, in med school, there was the whole idea that it is best taught in France and in other places, in the US and so on. That was like the way people aspire, and that it is our fault that we're not as good, that we are not able to do the medicine we are taught in the books. That's our fault. And there was very little critique. Like there was this just aspiration for people to go to France and study or to make the country as there, but there was a very little critique of what was happening that sort of reproduced all that. So in that sense, I do think that, yes, in the 70s, independence was very present and anti-colonialism was. And actually, even in the family planning and the choice that there is a strong national family planning, abortion was legal in 1973, or it was legal in France for all women above 18, married or not. And if they are married, partner doesn't need to give approval. And that's still the case. And that was an anti-colonial move partly. It was very much about limiting the number of the population and making sure that there is development and poverty reduction. But it was also a move against the colonial powers. So there were no funding coming from France. And Tunisia was also looking to work with US funding, Swedish, like international development. So there was some sort of work there that this place colonized us and we want to differentiate, which was not anymore the case in 2010.
Okay, I could keep asking you things for forever, but I want to make sure we have time for Q&A. So we have about 20 minutes for folks to ask questions.
Hi, I'm Batul. Thank you so much for coming and joining us today. I actually am from the MIRS program, focusing on the Center for Middle Eastern and African Studies. So this is very new to me. So this was really cool to hear about. You mentioned that you worked with, obviously, like with migration. So you worked with a lot of different refugees in different areas. There is a bit of stigma in the Middle East around mental health and seeking help for mental health, which is kind of like interesting because usually, I mean, I'm Middle Eastern, so I know that like my people have been through a lot of trauma and need a lot of help, and usually channeling that through therapy and professional help is like a really good way to do it. And yet there's a lot of stigma around it. So I just wanted to know how you navigated that through your work, and also did you notice that stigma and how did people overcome that, or if they overcame it, and like just the ways around that. I'm really interested to hear like your perspective. Thank you.
Thank you. Thank you so much. Yeah, that's a very interesting question. And of course, I was very biased that I did my fieldwork in a clinic. So the people who came to the clinic at the end. But stigma was very central in the discussion. And one of the things was that many of the people who were would say, I don't tell my friends and my people around me that I come to a therapy clinic because people will think that, oh, I'm too weak, I'm crazy. So that was very present. What was interesting, though, that for a lot of people, then part of their work was to destigmatize it. Some of them said, like, now I tell everyone that I go to therapy clinic because I think that I need to just, be open about it and maybe convince my friend or my cousin come. And that's, of course, the people who found that it worked for them, which is not everyone, because that's also the other part, I think. When trauma is related to strong political forces and violence, there was a lot also of resistance to make it just as a trauma. And for some people, that was also part of like, no, I cannot just transform this to a clinical condition that I can get treated for. So there were all these dynamics going together. And there was a lot to navigate in relation to the fact that people also maybe presupposed that people were stigmatized and didn't offer them mental health care, even though they wanted it. So a lot of my interlocutors struggled to manage to arrive to that clinic or to other places that gave mental health, because many people have this assumption. Yes, people from the Middle East won't accept that I suggest that they go to mental health clinic, and they didn't suggest it. And that's, I think, a whole issue many times working with other populations. So there were work with, I don't know now, I'm thinking in France with Roma population that they were not offered contraception, now that we're talking about that too, because there was this presupposition that Roma women don't want to use contraception. And then there is Médecins du Monde, who does this big study where, I don't remember the number, but like 80% of Roma women wanted to get contraception and didn't know how to get it. So there was also that I think is very important always to keep in mind, because we do, of course, have a lot of research where like high stigma in the Middle East, but this doesn't mean that we need to adapt it with like, okay, we should offer something else here.
Hi, my name is Ameen Khan. I'm a postdoctoral researcher at the Institute for Social Research. Thank you so much for this really interesting and interesting conversation that's made me reflect also on some of the work that I do. I focus on MENA and South Asian migration and one thing that really resonated with me is how you spoke about that happens kind of in the host society, like the place that people have migrated to, and whether it's around policy restrictions or, restrictions around healthcare pertaining to maybe like migration status, refugee status, etc. I wanted to ask if you have done any research in the area of like how, integrating socially and also economically, or like integrating within like co-ethnic or similar cultural community networks, how that kind of has any kind of, whether it's protective or risk factor on health of these like migrant communities.
Can you please repeat the question? What is?
Yeah, so have you done any work around like when immigrants or when refugees are coming into a new host society and whether they're able to integrate or not integrate within the host society, and then also if they're integrating into a network or community that's also similar to them, and how that can either help or hinder their health? Because I think there's evidence of both things happening in the literature.
Thank you. Yeah, actually, this is at the very center of my research in a way. So my dissertation in that clinic turned at the very end around that, because that was the whole issue, that people were struggling with all the disintegration that was happening, all the exclusion and the discrimination that was happening in this host society, that was making it almost impossible for them to have a stable life and to be able to rebuild a life. So I sort of find myself drawing this sort of vicious cycle that is like they need to heal to integrate. That's the idea. It's like, yeah, you're traumatized. You need to heal and then integrate. But in a way, they needed to integrate to be able to heal because they needed to have a stable housing. They needed to have enough food. They needed to have their family with them rather than still in a war place or in a refugee camp where they are worried about them. So it was some sort of a vicious cycle that couldn't be broken 100%, but that therapy was a place to accompany people across that. They were doing a lot of mediation work, trying also to work with other actors in relation to that. But it is indeed that, I think. And then being with other people, I think it is many times very complicated from when people are coming from conflict, because there is this idea that we homogenize migrants in general, but then we homogenize migrants coming from Syria or from Iraq or whoever. But these are not homogeneous groups. And they can be having also very different stance in the same conflict that are causing these exiles and being in different groups. So there is also a lot, I think, sometimes in relation to that happens, that people many times do not want to be in these places. It was a lot of a complex issue, even to find interpreters sometimes, because people needed to navigate all this sensitivity. So definitely one of the things people made them to the clinic beyond the therapy, and I think I will come back to hear your colleague's question about the stigma, but they wanted something beyond therapy. They wanted also to be part of some sort of collective where they were able to know we share the same struggle, not necessarily because we come from the same group or have the same thing. People were from different places around the world, but the same struggle that we come with this history of violence, and we still need to continue living under the violence of a racist society. So,
Hi, my name is Erin Lewis. I am a first-year MPH student with the Health, Behavior, and Health Equity program. Thank you for sharing everything. I really enjoyed hearing about your experience. Earlier, you had talked a little bit about the duality of learning in your medical school, learning in French versus the people that you were serving potentially speaking different languages or having a different first language, which made me think about here, me being attuned to a growing conversation around lack of representation of people of color in our medical textbooks in the United States, specifically with like graphics. So I was wondering if you had any advice for professionals in healthcare who may not be in these positions of structural change, of how to confront these things that can create great inequities and end up really affecting people's care.
Thank
Yeah. So I just want you to know, some schools on this campus need to leave at 10 of. So if people need to leave, that's not because they're not enjoying our session. There's like a disconnect between schools. So this session goes till 1, but if you do have to go because you have another thing at 1, we understand. So sorry to interrupt.
Thank you. That's a very good question and very important, and actually very central to something Scott and I are currently collaborating on. And just before being in Michigan, we were in this workshop that we were doing in the University of Chicago, working exactly on that. How can we make these whole structural forces translated into a practical, actionable tool for clinicians to be able to do something that is not changing the structure, because they won't be able to change the history of colonization or to completely eradicate racism or patriarchy from society. But what can be done differently in a way that will make it different for their own community, their own patients, and so on. So it is, a work in progress that we are working on. But there is already some work that has been done. So now we are working on having this sort of global case series, so trying to use the case model that is very much used in health education, but not to illustrate a medical diagnosis, but to illustrate a social force. And what is this point that maybe there is a possibility to do something differently? It can be just asking about answering a question about, okay, instead of having the assumption that this means that to you, just asking, what does that mean for you? Or if someone says, no, I don't want this treatment, not to say, oh, they don't accept the treatment that they own, but just sit with them and say, you tell me what would make it different for you? What do you want? What do you need? So there are a few things. And now I'm giving very simplistic examples, but maybe Scott can you work on that, because there has been already a case series that was published a few years ago that is working with some of that, with like racialization, medicalization, and so on. So there is already some work on that Scott can talk about.
So however much I would love to plug our case series, I want to just say something that I think is a little bit more just general and optimistic about, we often feel like even just learning the word decoloniality, decolonization, thinking about these forces is just can be a little bit disempowering, because you learn about all this very, very big stuff that's affecting you and the place you are with nothing to do about it. But I think we're starting already to see this kind of groundswell as people are armed with concepts that they're noticing all these concrete and intervenable things on their own. Like you mentioned, images more diverse in medical and health education. Well, med students who are on their dermatology rotation are starting to notice that like none of the photos that they are taught the way a lesion looks on the skin are in people with dark skin, which is just absolutely preposterous, right? Because things look really, really different in different color skin. So just like having a like a lens for that lurking in the background and noticing, people are starting to pop off these little things that they can, it's actually a super concrete thing you could do. Let's just take, every time somebody with dark skin comes into your clinic, take a picture of their thing and build a database, and people are now doing that, right? So this kind of anti-colonial or decolonial practice, I do think can have this kind of capillary or fractal type nature to it. I don't know if that's a helpful answer.
So if I heard correctly, you said that you did your medical education in Tunisia during the 2010s. I don't know if you'll have like an answer to this, but at that same time, there was a large demand for social justice and just change the system. Did you notice, I guess, any transformations in the medical system there, or just how public health was approached? Just because that was a major issue that was, facing Tunisians, especially in the rural areas.
Thank you. Yes, that was the big part, of course, of the context. And I think it is interesting to see that, of course, medical students were part of organizing and going out for demonstrations, and that was part of being part of the bigger protest. That was not only related to health, but it transformed a lot into a demand for more, equal healthcare, for more dignity. There are big disparities between rural and urban, between big cities and small towns, and there's this part on the coast and the North Coast in Tunisia has been sort of a fracture. And that was there were associations, civil movements that started actually really working and advocating for that. Unfortunately, I don't think it definitely changed education. Maybe because education is just slower to change, the curriculum and so on, and the conversation. But I think that's part of what is one of the things that is medicine. What made me, I think, need medicine at some point was that the social was not present. That when you are in the school, it's only the technical part. You are learning about the diagnosis and so on. It's very little about everything else. But that was happening in parallel, with students' movements, interns, residents, really organizing a new association, starting, speaking in media. So that was something that happened, but not in the wall of the school in that sense. But it did, of course, I think it was one of the main motors was brought things to people.
One more. Yeah.
Thank you so much for a wonderful talk. Gurpreet Rana, Global Health Informationist, Health Sciences Library. So many of us have recent forced displacement in our family histories. And I wonder if you've worked with children in the clinic, because it's interesting how that manifests as they become adults, and then how it goes into the next generation. My parents were child refugees. And so just thinking about that experience and then how it's impacted me, but also how 70 years later, they can't forget. They remember every single detail. And I wonder how you've had those experiences with children, and if intergenerational trauma is something that you have been studying.
Thank you so much for the question. Unfortunately, I haven't been studying children per se, as the clinic was only for adults, but I was around because most of these adults are children. So these questions were happening a lot, and usually they were taking their children to other health centers and so on. So it is not my object of research per se, so I don't want to say things I don't know in that sense. But it is very much at the center, I think, of what we need to be very aware of. And that's why we cannot study the present of individuals, of countries, of the world, without looking at the history and everything that happened.